So this is the second half of the endocrine lecture. In this section, we are going to talk about a couple of hormone relationships between the hypothalamus, pituitary, and end organ axis. So the hypothalamus, we know, is a part of the more central, more primitive brain. It's not the cortex part, and that is right below the thalamus, which we know is a relay station. So the hypothalamus and the pituitary, and especially the anterior pituitary gland, have a special circulation. It's a portal circulation, similar to the capillary or the venular bed between the small intestine and the liver. That communication is just in between those two organs only. So if the cortex is sensing something about the environment and that gets relayed down to the hypothalamus, that could trigger the release of these types of hormones, which would then send a message to the anterior pituitary to release their hormones, which would then end in whatever end organ we were discussing. So that is a very complex negative feedback mechanism that occurs and is sometimes triggered by other events like stress, as well as different times when we go through different growth spurts, we can increase the release of some of these hormones. The big point here is that when the hypothalamus releases a hormone, it will only affect the pituitary gland because of their special connection. The other side, the posterior side of the pituitary, has a connection that's a nerve connection, only between the two. And that's where we release the antidiuretic hormone, which we'll talk about in the renal lecture, and oxytocin, which is for labor and delivery and breastfeeding. So the point is the hypothalamus and the pituitary gland have a discrete relationship that is not shared with the general nerve and bloodstream. But if something is triggered to occur in the hypothalamus, it sends its message to the pituitary gland. The pituitary gland creates its hormone, and that's the hormone that goes in the general circulation to whatever target gland to promote the production of a hormone there, which then affects the body. So the two hypothalamus, pituitary, end organ relationships that we're going to talk about have to do with the thyroid gland and the adrenal gland. There are others. There's growth hormone, which affects muscle and bone length, and there is a normal level of growth hormone for muscle repair, but it is triggered in times of growth in infancy and adolescence. There's the hormones that drive the menstrual cycle. The gonadotropin releasing hormone from the hypothalamus goes to the pituitary to create follicle stimulating hormone or luteinizing hormone that affect breast development and the uterus and ovaries, and that is a cyclic change that occurs with the menstrual cycle. That is also the system in the man that will promote the production of testosterone, responsible for secondary sex characteristics and spermatogenesis. And that information is in this PowerPoint as for your information, because certainly depending on what track you're in, that information will have different levels of importance. It is not on the exam, so of course I know what that means for you at this point in the semester, but it is something that you will have to know. We are going to talk about, like I said, the thyroid gland and the adrenal gland, and we'll start with the thyroid. So the thyroid gland, that's our end organ. That's a very important organ in the neck that is in charge of metabolism of the body. So it is also important in growth and development, and it is important in the stress response, because in growth and development and the stress response, the body's metabolic demand increases, and thus the activity of the thyroid gland should increase as well. The body is trying to maintain a certain level of thyroid hormone at all times. And so if I'm looking at the, this is our negative feedback system kind of thing that we talked about with diabetes. This is my range of thyroid hormone that I would expect in the body at all times. It probably, the range that the body requires could increase in certain times, but mostly it's within this range. If the level or the thyroid gland is starting to increase production of the thyroid hormone and we don't need that, that should be, with our negative feedback mechanism, a decrease in stimulation of those stimulating hormones from the hypothalamus and pituitary. So we should decrease the production of thyroid releasing hormone from the hypothalamus and thyroid stimulating hormone from the pituitary. If the level starts to go down or our need is greater, then that would increase stimulation from the hypothalamus and the pituitary. Another way that people sometimes represent this in negative feedback form is the thyroid releasing hormone from the hypothalamus travels that portal circulation to increase production of thyroid stimulating hormone in the pituitary gland, which then travels to the thyroid to increase production of thyroid hormone. When this production increases, that is negative feedback to both the hypothalamus and the pituitary, because I have enough. These are positive stimulating. Please make this hormone. If I have enough, then I'll turn it off. When thyroid stimulating hormone is released, it attaches to receptors on special cells inside the thyroid gland, or special complexes, tissue complexes inside the thyroid gland called thyroid follicles. So the thyroid gland is made of cells that produce calcitonin, which we talked about in the beginning of the semester when we were talking about calcium balance. I hope you remember that way long ago. And then there's the thyroid follicles, which are what produce thyroid hormone. The thyroid follicles have receptors on them called that are sensitive to thyroid stimulating hormone. So when thyroid stimulating hormone is released and travels in the bloodstream to the thyroid gland, it sits on receptors that are located in the thyroid follicle to promote the influx of iodine so that the thyroid hormones can be created. So the building blocks of the thyroid hormone are inside of the thyroid follicle. They just require the iodine. T3 has 3 iodine molecules, and T4 has 4 iodine molecules. And then they can go into the bloodstream. So the way thyroid hormone acts is then T3 is the actual active thyroid hormone. T4 is an inactive form of T3 that gets activated mostly in the liver. And then this is what determines the action. T3 and T4, some of that is free in the bloodstream, and T4 is waiting to get activated to T3. And some of these are riding in the bloodstream on carrier proteins. Specifically, there's thyroid-specific carrier proteins and albumin. And they're sort of our reserve. So we have this freely floating active and inactive thyroid hormone. And if that level starts to get low, we can release the T3 and T4 from the carrier proteins. So we kind of have a buffer for production. So obviously we need iodine in order to do this to begin with. But in our country, it's iodine deficiency is not very common because even in foods, a lot of foods are iron fortified. And I'm sorry, iodine fortified, and iodine is in salt. Our salt is iodinized, and clearly Americans get enough salt, even if people have nutritional issues or their food supply isn't as stable. They usually have access to salt in some way, and so iodine deficiencies aren't common in the U.S. And people don't usually need iodine supplementation, although there is some people that advocate for that. I'm not sure that the evidence is there for that. So now we have the biologic activity of the thyroid hormone, and that is, of course, bone and tissue growth, metabolism to support bone and tissue growth. So that means increased breakdown of glycogen stores and fatty stores of glucose, increased protein catabolism to feed metabolism and to build red blood cells that we need in order to do that. It also sensitizes epinephrine and norepinephrine, which means we will have an increased ability to raise our blood pressure and our heart rate if needed in times of stress. So very important. That next slide is showing you the picture between the hypothalamus, pituitary thyroid gland, and the active hormone in the bloodstream. And that's slide 19 if you're following that way. So there can, of course, be alterations in thyroid function. You could have hypothyroidism or hyperthyroidism. And thinking about it in terms of metabolism, you can decide what sort of symptoms that would show up. So if I have hypothyroidism, my metabolic rate is decreased, and people will have several types of symptoms from that. They will have the potential for low heart rate, low blood pressure. They will be cold. They will gain weight because it's part of fat breakdown. They will have constipation. They usually have a change in their skin and nails. It's usually dry. Their nails get brittle. And then they can have an accumulation of mucopolysaccharide substance in the connective tissue, so it can kind of give them a waxy yellow sort of appearance sometimes, especially if there's a very large problem with the thyroid that's gone unnoticed for a while. Whereas hyperthyroidism, the metabolic rate is increased, so they have a possibility of increased heart rate and blood pressure, insomnia, anxiety, sweaty, heat intolerance. They have diarrhea usually, there's weight loss, so everything is revved up. So why do those things happen? Hypothyroidism in general is a problem with the thyroid gland itself. So why would I have trouble with the thyroid gland? Well, it could be just a lack of iodine. That means that even though these hormone systems are trying to work, the thyroid can't make the thyroid hormone because it needs iodine to do that. But as I said, that's not very common here. The most common reason why people in the United States have hypothyroidism is a condition called Hashimoto's thyroiditis, which is another type of hypersensitivity reaction where there's immune infiltration of the thyroid gland and that decreases its functioning. And that can happen in times of stress, after illness, pregnancy, etc. Sometimes triggered by other viral infections, we might not even know the trigger. So if my thyroid gland isn't working, the follicles aren't producing the thyroid hormone like it's supposed to, then I will have the symptoms of hypothyroidism, which are the symptoms of a decreased metabolic rate, which we talked about, as well as what's called myxematous tissue, that waxen and swollen tissue we talked about because of the polysaccharide infusion in different types of skin and collagen cells. So say I was wondering if a person had hypothyroidism based on their symptoms. I could do blood tests to look at this, and these are potential test questions. So if I suspect hypothyroidism, I could actually test thyroid levels directly. I could test T3, I could test free and bound T4, I could test the different thyroid proteins that are supposed to be binding these hormones to see if there's, you can order all kinds of stuff. It doesn't necessarily mean you need to, but I would expect in hypothyroidism that these would be low. But if the problem isn't the hypothalamus or the pituitary, then I would expect these hormone levels to actually be high because these parts of the body are trying to get the thyroid gland to work. And so sometimes people measure thyroid function indirectly. They might actually this would be this would probably be normal, the too high. But they might check it indirectly and say, okay, I'll check thyroid stimulating hormone because if the thyroid gland isn't working, this would be high because it's not responding to the stimulator hormone. So sometimes you'll see that people will just check thyroid stimulating hormone and monitor or manage thyroid hormone supplementation based on that, because that's an indirect measure of thyroid functioning. If the problem was someplace else, say the thyroid gland would work just fine. This is low, but this is really low. This maybe the problem is the pituitary. You can have hypopituitary function, in which case the hypothalamus would be trying very hard to stimulate the pituitary gland, but if the pituitary gland isn't working, then it won't send the message to the thyroid. So the thyroid gland could be functioning just fine, but it hasn't been told to make any thyroid hormone. This is not obviously as common. Even less common would be a complete breakdown of this whole thing. So say the person had traumatic brain injury or something, maybe that affected their hypothalamus, and now they're not even making the hormone that would tell the pituitary gland to work, and so they're all low. So you could, if you weren't sure, actually test all three to see what the problem was. But common things are common. Always remember that. You can spend a lot of money on people, but if they have the usual symptoms of hypothyroidism, it's probably the thyroid gland. But if you think about it, which you should, you can expect different hormone levels depending on the level of the problem. So the extreme problem for hypothyroidism is a condition called myxedema coma, in which there's complete cardiovascular collapse because of needing the thyroid hormone to bring the blood pressure and heart rate up. Not very common in this country anymore because we usually can pick up on this issue and treat it effectively. You can have congenital hypothyroidism, meaning you're born that way. It's essential for growth, and so you can get, you will have delayed and developmental delay, and you'll have issues with growth and development in infancy and toddlerhood, and you develop a condition called cretinism, which is also not very common anymore because we usually test for this to be sure we can catch it early. The opposite, of course, is hyperthyroidism. So you might suspect that because the patient has symptoms of hyperthyroidism, which is the increase in the metabolic rate. And that disease is in general called Graves' disease with hyperthyroidism, and that's an autoimmune disorder where there is increased stimulation of the thyroid gland by an antibody, a thyroid stimulating, immunoglobulin, that is what's acting like TSH on the TSH receptors on the thyroid follicle. So in this case, these are low because it's not the thyroid stimulating hormone that's increasing the production of thyroid hormone. There's this extra circulating immunoglobulin called thyroid stimulating immunoglobulin that's actually telling the thyroid to increase production of thyroid hormone. driving the increase in iodine inside the thyroid follicle to produce more of those hormones. Then there's a familial tendency to this disease. We don't always know what the cause of it is. The worst manifestation, just like myxedema comas for hypothyroidism, is thyroid storm, in which the person will have cardiovascular issues on the opposite side, hypertension, agitation, tachycardia, etc. So in this case, the treatment, instead of obviously adding thyroid hormone, we would try to bind the thyroid hormone. And if I would check, like I said, if I would check this, I would find that the problem, I could still check it indirectly by checking the thyroid stimulating hormone, and I would see that this was really low because the negative feedback mechanism is still working, but the thyroid level would be high. If the problem was in the hypothalamus, or sorry, in the pituitary gland, then that means maybe there's a pituitary adenoma that's increasing production of hormones. Then the thyroid stimulating hormone level would be elevated, which is causing elevated thyroid hormone levels. And in that case, the hypothalamus levels will be low because that's not the problem. So you could do a workup that included the entire chain of command, but in general, common things being common, it's Graves' disease. It's this production of immunoglobulin. So the most common hyperthyroidism condition is Graves' disease. The most common hypothyroidism condition is Hashimoto's thyroiditis. And then we're going to talk about the adrenal gland. So the adrenal gland is located above each kidney. It has mineralocorticoid and glucocorticoid hormone function. So the mineralocorticoids, that's aldosterone that is produced. The glucocorticoid is cortisol, and then it also produces sex hormones as well. It is also part of what creates epinephrine and norepinephrine and can be stimulated by the sympathetic nervous system to do so. And it is a big part of our stress response. So cortisol levels are a little bit harder to measure because they change depending on what time of day it is, because your wakefulness, which is it's part of, will change throughout the day. Obviously, you don't need as much cortisol at night as you were during the day. So there's a circadian rhythm to it. It changes depending on if you're a man or a woman. It depends on the stress level of the person, because their cortisol levels increase in times of stress and illness sometimes, and decrease when that's not the case. So you can't just measure a cortisol level and say, oh, okay, I see this person is in range or out of range, because there's a lot of factors that determine it. But cortisol is a big part of the stress response. It helps by fueling glucose metabolism. So in the time of stress, now remember, whenever we think of the stress response, we think of it in evolutionary terms. We are a machine that was created to deal with extreme hunger, thirst, and trauma related to our previous prehistoric lifestyle, which was fighting amongst ourselves in different clans, getting attacked or chased or whatever by different animals. So when we were under stress, it was a physical stress. We needed to be able to run and fight, or we needed to be able to make food sources for ourselves when they lacked, or save fluid if we were dehydrated. So that is not obviously as helpful now. If your stress is schoolwork, or trying to put together a class on YouTube instead of giving class like you normally do, then increasing the availability of protein and glucose and increasing heart rate and blood pressure are obviously not as helpful. So think of the stress as a body stress, not a mind stress, even though cortisol will be released for both. So when cortisol is released, There's an increase in glucose metabolism and gluconeogenesis, so blood sugar should go up. Proteins are broken down as well. There's increased glucose, protein, and fat metabolism in order to provide energy sources. We suppress things that use body energy, so especially the immune response will suppress it in order to divert our attention elsewhere. And again, we will help catecholamines work better, which brings up our blood pressure and heart rate in times of stress. So it's perfect for the types of stress that we had in prehistoric times. This runs again in a negative feedback loop similar to the thyroid gland, in that there's a hypothalamus stimulating hormone, a pituitary stimulating hormone, and then action on the end organ, which in this case is the adrenal gland. So in times of stress, which can be detected by our higher brain levels or not, corticotropin releasing hormone is released to stimulate the anterior pituitary to produce adrenocorticotropic hormone, which tells the adrenal gland to produce cortisol, which will perform these functions. And then, if everything was working normally, once cortisol levels were increased, that would decrease the production of the stimulating hormones because we don't need it anymore. So it should be a loop mechanism, so we only get what we need. We don't overproduce or underproduce. However, obviously conditions exist where the adrenal gland is underproducing hormones or overproducing hormones. So the first thing that's listed there is adrenocortical insufficiency, which means the adrenal gland either isn't working or there's a problem higher up the chain, but the issue is we don't have enough cortisol. The primary adrenocorticotropic insufficiency, meaning the adrenal gland itself isn't working, is called Addison's disease. So that is another autoimmune condition, and people can develop it congenitally or what have you. They're not going to have enough cortisol, and their biggest symptoms will be fatigue and hypotension. If I would check their blood tests, the adrenocorticotropin hormone itself will be very high because these mechanisms are working. The pituitary is pretty much yelling at the adrenal gland, please produce cortisol, but it is unable to. You could have secondary adrenocorticotropic cortical insufficiency because of general hypopituitarism, which we talked about, same with the thyroid gland. You can have an acute adrenal crisis in times of profound stress, if you can wear it out, in other life-threatening situations, which is why, especially if you work in the ICU, you might notice that sometimes you just start giving people hydrocortisone because you're trying to support that. So, clinical findings in adrenal insufficiency, besides obviously the profound fatigue, weakness, you might have GI symptoms, hypotension, and low sodium. So you might, why is that? Well, because these are the other hormones in that same area of the adrenal gland, which can also be affected. So aldosterone, remember, is the hormone that's part of the renin, angiotensin aldosterone system. And when aldosterone is active, we are supposed to save water, which could potentially bring the sodium level down if we're saving lots and lots of water. I'm sorry, strike that completely. We're supposed to get rid of water and sodium and keep potassium. So we can change fluid balance as well in terms of adrenal insufficiency. If that isn't working, then we're going to get rid of sodium and lose water potentially, which would decrease our blood pressure and keep potassium. So we would have the hyperkalemia The other finding would be an increased pigmentation, and that's because adrenocorticotropic hormone is also related to stimulation of melanin in our skin. So people who have adrenal insufficiency will have an increase in adrenocorticotropic hormone release, which increases pigment. And then they might have other associated disorders. So just to be clear, because I kind of fumbled out a little bit, so I want to be sure you understand. In the setting of adrenal insufficiency, I have a decrease in cortisol, which means I have a decreased ability to respond to stress, and I could have fatigue and change in my vital signs. But I also will decrease my production of aldosterone. And aldosterone is supposed to increase sodium in water and get rid of potassium, because aldosterone is supposed to help us save fluid. But if we're not doing that, then we'll have a decrease of sodium in water and an increase in potassium. And that's important because these hormones go together. So be sure to remember that. So that's Addison's disease. You could, however, have a problem where you're increasing production of cortisol, and that's Cushing's disease. And it could be that there's a tumor here overproducing cortisol, or it could be there's a tumor here overproducing adrenocorticotropic hormone, which would then end up producing more cortisol. It could be also, unfortunately, some cancers can mimic production of hormones, and small cell lung cancer often will produce increased adrenocorticotropic hormone, causing problems, even though it's not really a problem here. It's just an extra hormone being secreted by a cancer. So excess Cushing's disease means that your blood pressure could go up, you could have muscle wasting, fat metabolism changes, so you keep fat centrally and decrease it peripherally. You can have increase in blood sugar, and then it would be the opposite, electrolyte abnormalities. People usually have an increase in sodium and a decrease in potassium. Some of the other irregularities, there can be an increase in testosterone production, so there can be increased hair development in women, which is called hirsutism, or there could be menstrual irregularities as well, because these other hormones might be affected.